to send it on to. So one of the first things we look at is the details that we've been provided for the child. Something that does happen often on our form is I'm not sure if it's just unclear, but the first section where it asks you to detail the person of the concerns is just to make sure that's the child's details and not yourself as the referrer. And we're looking at the address of the child. Are they living in Suffolk? If not, is it very clear as to their situation and where they are residing and why the referral has come to Suffolk if they're not a Suffolk resident? We look at the quality and the quantity of the information we've been provided with. So for more urgent concerns, we can go with sort of less information, but we do like to have enough information that we can then triage that effectively and send that on to the relevant team. We also look at the children that are being referred. So sometimes you might be referring just one child, sometimes it might be a child and their siblings. It may be that you're referring multiple children from across different households. I don't know, it might be like cousins, or there's been an incident that involves two families. In those cases, we will ask you to submit a MARF for the additional children as well, so they have a referral in their own right. If we don't have enough information, we will give you a call or email you, whichever is more appropriate, to get that additional information so that we can forward that on and that process isn't delayed unless it needs to be. And then the urgency of the referral. And the urgency of the referral does, from that we kind of get a sense of where we need to be sending the referral to. So it could go to MASH, an allocated worker or an early help team. And I've just got a little bit of a flow diagram here, just showing you what happens after we've triaged. So in Customer First, we triage the referral. We look at if there's an immediate, an urgent concern for the child, and then from there we determine where that goes. So if the child has is open to early help and they have an open CAF, and it's a less urgent concern, we'd send it to the early help team. If there is an immediate urgent concern for the child, if they have an allocated social worker or a social care team that they're open to, the referral will go to them. If there is no open allocation, then the referral will be sent to MASH. If there's any questions at this stage, that's all I have. That's quite simplistic in Customer First. We just take all the initial information, make sure we've got the information we need to send on, and then make that decision as to which team we send it to. Alex, do you have a question?
Yeah, thanks. Just in terms, when you say sort of like quantity and quality of the information in the referral, have you got any sort of good examples of, not now, but can you share kind of good examples of referrals that people might want to look at?
Yep, definitely. That's a really good idea. We have got some examples. Oh,
Laura, I was going to say we're going to cover some MARFs in our presentation.
Oh, amazing. Great. Lovely. There we go, Alex.
Sorry, I didn't want to interrupt, but
no,
yeah.
That's perfect.
Okay.
Okay. Any questions from anyone else? No, lovely. Is that over to you, Barbara, or?
Yeah, Tracy, you're happy for us to start?
Sorry, Barbara. Yeah, that's fine. Yeah, absolutely.
Okay. So we've got a presentation as well. I'm Barbara Metcalf. I'm one of the CYP practice managers in the MASH. I do have a colleague, Ellie Evans, who is also a manager, but with me today I've got Millie Clark, who is one of our very experienced consultant social workers. So yeah, we're going to do a little bit of a presentation. Apologies, we may sort of be, it may be quite repetitive because obviously some of the things we do are similar to Customer First, and apologies as well if you already know some of this stuff, but I think that we're going to touch on some stuff you may have already heard in other presentations, but just I always think it's good to just remind people of, you know, who we are and what we do. So the MASH, so the Multi-Agency Safeguarding Hub, was sort of developed in different areas because of findings from serious case reviews, and you know, the whole concept of having a team that was totally multi-agency was deemed to be the best way to look at safeguarding children. So we are what we say on the paper. We are really multi-agency. You know, we have police colleagues, we have health colleagues, we have DA colleagues, We have, they're actually on the floor plate with us, and they sit alongside us every day, and we discuss cases together and we gather information. We've also got our external partner agencies, which are people like yourselves in education or health. We've also got youth offender and probation, housing. I mean, any professional really that the MASH deem we need to get information from, we will have access to somebody that can give us that information. You'll be hearing from Sarah Markham later, who's my counterpart in the MASH adult team. But we are quite unique in Suffolk that we do have adult MASH sitting alongside us as well. I don't think there's many other MASHers that have an adult team within their MASH team. So we are the single point of contact for unallocated cases. As I said, we've got the multi-agency concept. And we have a holistic view of a child, young person or adult who are at risk, really. So, anybody that's, you've got a concern about and there's risk identified, they're the kind of things that will come into us. So, as I said, we've got a very close working relationship between a variety of professionals, which enable a quick and accurate response and analysis of the risk. And it is that actual, the fact that I can get up and go and talk to a police officer and get some details of somebody that I'm worried about straight away, that really makes our job, sort of worthwhile and easy. Okay. So when the MARF comes into MASH, so it comes into our incoming tray. We have a CSW who monitors that tray. Just to give you a little idea of some figures, the last quarter, which is obviously 3 months, we had 9,700 children coming through to MASH. So, as you can imagine, that's quite a lot of contacts to read and to make decisions on. So only 12% of those cases transferred to our colleagues in Child in Need under Section 17 social work assessment or Section 47. And that resulted in 1,142 children. So all the other children were dealt with solely in the MASH or referred to early help, or they might have had some other support put in for them, or referred to another agency for support. So when that MARF come in, we will be looking at, have we got the information we need in order to make a decision on it. We rely quite heavily on our colleagues in Customer First to have put that information on, and that's why it's so important, and we'll go into more detail about the MARF, but just details around addresses, names of children, dates of birth, etc. are so important to have, and for them to be correct. But as I said, we'll touch on that a bit later. So when the MARF comes in, that CSW does another triage. So it's already been triaged in Customer First. Customer First does alert us if they think that there's been a red or an amber, because they're the ones that we need to look at first. But then we do another triage. So our level 4s, which are the children that are most significant risk, we aim to deal with within 4 hours after it comes into us. The level 3, which are children that are likely to need a social work assessment or some higher level of support, we try and deal with within 24 hours. And then our level 2s are children that are more likely to be able to have support for universal services. We don't use level 1, but that is something that's there, but they usually are sort of things that we take no further action on, or we might just make one phone call. The police do rag things as level 1, and they're low level sort of antisocial behaviour incidents, or just things that don't actually need any social care involvement. So the main things we use are the red, amber, greens in the team. Okay. So we've got a referral journey as well. So as we said, the referral is made to customer first, comes into our MASH incoming hub where that triage process takes place, and then we send it off into other hubs within the MASH. So within the MASH, we've got an incoming hub, which is usually a MASH practitioner who, and these are low level things, who will just make a phone call to a parent or another professional, and they're resolved straight away. So they only kind of stay in the incoming for a day maximum. Our aim is to turn those over quite quickly. Then we've got our assessment hub. In the assessment hub, they're usually your green stroke ambers. And that's when we've deemed that in order to make the best decision, we need to gather more information. So we will pin this out to partner agencies to give us information. It might be police checks, health checks. We will often and very often ring the DSLs in schools to get their views and information about the child, young person. We might ring probation if we know that a member of the family is on probation. So that's where we gather all the information in that assessment hub. And the outcomes there can be, a variety of things, but it's usually things like information and advice. So we've gathered the information, we've deemed that this does not meet the threshold for social work assessment, but we have given information and advice either to the referrer or the parent carer. We might decide that a CAF is the best way forward for support for this family, and we will either broker that CAF from the MASH or ask other professionals to complete the CAF, depending on who knows the family the best. So yeah, that can go over to our colleagues in early help. And the other thing that might happen is there might be a social work assessment. And that's if the threshold is met for that social work assessment under section 17 and the child is needing longer term sort of risk assessment, a more sort of in-depth assessment. And they go over to our colleagues in the SIN teams. Our red hub, as I said, is where when it first comes in that we think this child is suffering significant harm or likely to suffer significant harm under section 47. And what happens in the red hub is there's a team of professionals, so a health person, a police decision maker and a consultant social worker, and they'll hold those red cases and have what we call a threshold discussion if needed. And I know that some of you here may have been invited to those threshold discussions to take part in those. And we, paediatricians attend those as well if the child's got an injury and we deem that, they might be needing to have a paediatric appointment. So they're called our threshold discussions, and we can have up to 10, of those a day. Sometimes there's less, which is good news for us because they are quite timely. And obviously, we do need to make sure that, children with injuries or children who have been sexually assaulted are seen, in a timely fashion. But the outcome from that might be that it's a joint section 47 or a single agency section 47. And that's where the police will either go out on their own or social care, or police and help social care together. Might deem that a social work assessment is the best way forward. So there's no, sort of real risk to the child, and we can assess that and support the family for a social work assessment. or it might even be information and advice CAF, depending on what the threshold discussion determines. But it is sharing that really important information. I mean, the police will look at criminality, they will see if, you know, there's been any criminal act here. We obviously look at the social care side, and health will look at any health needs. But they're always multi-agency discussions, as I said, and inviting any other professionals who you feel might be able to contribute and, you know, make the best outcome for the child. Okay, so that's a referral journey. So then we'll move on, unless anybody's got any questions about that bit as to what makes a good referral. No? Okay. And I think Millie's, you're going to do this bit, aren't you?
Yeah, hi everyone. So again, I'm probably going to cover a couple of points that Barbara and Laura have already mentioned, so I apologise if there's any repetition. As Laura said earlier, the current risk to the child and all the children should always be the priority when completing the safeguarding referral, and there should be a consideration if there's an immediate or urgent risk to that child for calling that through to customer first in the first instance and following up with the MARF later on. Again, it also might be appropriate to consider contacting police if it's clear that a crime's been committed. They have quick powers to respond sometimes to those sorts of incidents, so it's always really important to consider that. So I'm going to move through a little bit through kind of the sections of the MARF and talk about what makes a good referral and what things really help us in the MASH to progress things as quickly as we possibly can. So informing those with parental responsibility of the referral. They don't have to agree with the referral, and that needs to be really clear. We're not asking them to agree to you putting a referral in. The referral is your duty in your safeguarding roles to complete, but they should be informed where it's suitable that you're doing so that it is not coming, they're not unprepared for it. They are likely to be contacted by ourselves. Obviously, there's always exceptions to those that happening. If that child's going to be put at further risk, and it's a really, really clear rationale as to why that would put the child at further risk by contacting somebody with parental responsibility, that shouldn't really happen. You can always seek further advice on the professional consultation line about whether that should happen, but rationale should also be really clearly outlined as to why parents haven't been informed of that referral being submitted. Again, touching on the basic information for family members and other important contacts, it's really, really vital for us that we've got up-to-date names, dates of birth, the relationship to the child, up-to-date and current addresses, and current contact numbers. It makes our job much quicker if we've got all of that information in front of us. Otherwise, we can be sort of searching for that information on various systems to try and find out the best way of making contact with that family. Any information that you've got in that is really, really useful. Dates of birth aren't always available, and we do sort of appreciate that. But if you do have that information available to you, it makes things like police checks an awful lot quicker. Right, so MARFs being really clear and concise. Obviously, you've got a lot of information to share about children. You're the ones having face-to-face contact with these children. You know the most about them. However, that incoming hub that we have is manned by a consultant social worker who's reading up to 100 or so sort of contacts on a daily basis. So that information needs to be really, really clear and really easily presented so that we can clearly see what the current risk to that child is and how quickly we then need to respond to it. Again, clear and simple language without the use of acronyms. We're quite good at decoding quite a lot of them, but we don't know all of the acronyms in all of the different areas. So being really clear with your language is really, really important as well. The presenting issue, so what is the current concern? A lot of the time we know there's quite substantial history. You may have been concerned about the child for some time. That's all really relevant as well, but we need to know what's going on for that child today, and what's important for us to be focusing our attention on in the immediate. If the child's got any injury, is there a good description of that injury? So using some very descriptive language. Has there been a direct disclosure from the child? Is it a third party disclosure who's that you've had? Have you got any images that can be provided if it's obviously appropriate to do so? So the impact of the issue. So what impact is it having on the family, and particularly on the child or the children in that home? Again, timeframes of risk are also incredibly important to understand. Is there anything that's going to change that? Is it a case of the child's going to be collected from school in 2 hours and actually you'd really need some contact prior to that? Is it something that can be sort of dealt with more slow time? It's an ongoing concern, something that you are still worried about, but we can kind of work through within our 24-hour block, for example. Also, what support's already been offered or completed? So has a CAF been explored already with the family? Have they been signposted to other universal services? Have referrals been made to any partner agencies or any charities that are supporting them? Also in the immediate, so if we've got an immediate safeguarding concern, what steps have been taken to make sure that child is immediately safe? Have police been contacted? Is there a safety plan in place with parents or with extended family members? Anything really that's already happened to date that would be relevant for us to know. Underlying needs. So we know that children have a wide variety of needs, and it's really useful for us to know if there's anything that's going to impact particularly on that child. Do they have any sort of additional needs that need to be taken into consideration? Are there language barriers? Is there anything that we need to know about before we approach the family? And history, as I said, is very, very important. Often there's a long chronology of sort of bits and pieces that have raised concern, but maybe haven't quite met the need for a MARF to be submitted, or there's been substantial history previously that is relevant. A summary of that previous involvement is really important for us to understand, but again, not to an extensive sort of level. If that can be sort of a brief summary of what exactly has happened and any significant events, rather than sort of a full chronology of the concerns. The voice of the child, very, very, very important. What have they said about the concerns? Where possible, obviously, we appreciate some children are not able to express that, or are not old enough to express that themselves. Where that's the case, sort of an understanding of how that child's lived experience is also really important, particularly as you guys are usually the ones who are having that contact with them and will know them in a better depth than we obviously will behind a screen. Network of support that's available. So all people living in the household, we know from a number of recent serious case reviews that it's been flagged that people living within the household have been missed in inquiries because they're not blood relatives of that child. It's really important we know exactly who is around and who we need to be sort of looking into, or we need to be contacting. The same as any extended supports outside of the family. Grandparents, auntie and uncle, mum's best friend who's offering support on a daily basis. They're really important contacts for us to know about so that we can look at the whole picture for that child and exactly who is in place. Okay, so we've got a couple of examples of some MARFs that we've had come through that are sort of good quality MARFs in our sort of eyes. They've all been anonymised. They are real life MARFs, so if there's any sort of bits that you recognise, please keep them to yourself. But they have all been anonymised and all the names have been changed, including the names of professionals involved, just to make that clear. Let me just load these up for you. Right, so this is the system that we do use within MASH and with it across Suffolk County Council for social care. So this is how these referrals would look as they came in. So we'll start with Ben. So Ben was a referral from the health visitor. As you can see, there's telephone contact number has been provided, email address for the referrer, They've covered the fact that they have spoken to mum and that mum understands why the referral's being made. Moving on to the main contact information, it's not sort of too extensive that it's going to take us ages to read, but we can very clearly see straight away what the concerns are. This child had presented with marks to the neck. Again, descriptive language has been used, so red blisters. When the child had been collected from dad, an account has been given from mum that mum had spoken to dad and the child had been smacked, and mum had taken the child to maternal grandmother. Some of the child's views have also been mentioned. So the child had stated, "I don't like daddy," when dad was spoken about. All of the areas of kind of within the MARF have been covered, but again, we've got the very vital information is there. So we can see that there's some history, domestic abuse, that mum had fled abuse and that she'd stayed with a family friend. We can see which grandparents were involved just from a very, very brief sentence. And what support's already been done. So we know that mum has put in support around domestic abuse, that housing were involved and that was being done, and that she was seeking medical advice around his injury. So this was just one of our examples, really, of a really quick and easy way for us to see exactly what the presenting issue was. It's clear, it's not too long, but all the information we need is there for us to get started.
Yeah, and I think in cases like this where there is an injury and we have got, a kind of disclosure or, a description of what's happened, is that just for you as referrers, those MARFs can be very succinct. They don't have to be really detailed because we'll be getting more information from you after. But what we really need to do is make sure that we safeguard this child, as soon as possible, really.
Definitely. I'll just take another look at another one. So this is Penny. Again, this one's come from school. Again, all of the contact information is there, position of the person who's referring and their name, all of their details. Again, mum has been made aware. This time she wasn't very happy about the referral being made, but that's documented that she was upset about it. But the referral has obviously still been made regardless. This one's a little bit longer, but the information is all there and clear for us to see. So we can see very clearly at the top that they've outlined that there are concerns relating to the child's behaviour, and then gone into more detail below with the accounts of other children. That was all anonymised by them as well, which is really useful because we know that we can contact the referrer and say, can we have the details of the other children if needed? But for the sake of this child's record, that's been anonymised already. They've included the child's views, so they'd spoken to the child and obtained their account and put that on there also. On this occasion, the referrer had contacted the consultation line and had sought some advice. They've included the fact that they've done so in their referral. They've told us where the family were previously living and that there might be previous concerns, but they weren't obviously sure. And they'd contacted the previous school to obtain any further information regarding that child to share with us as well. So again, it was really, really clear and very quick for us to see exactly where that needed to go. And then our last one is Jack. So the same as the previous two on this front page. Again, it's all been completed and it's all really quick for us to view. Again, this one has a reasonable amount of information within our concerns part. It's gone into details of what the concerns have been previously or recently, and what has happened, what has developed throughout that morning to make them complete a MARF for this child. Very clearly got the views of mum. We've very clearly got all of the information and all of the concerns there that they have got, but again, it's not extensive information that means it's really difficult for us to read and quickly see what we're looking at. They've considered the child's views, and they've popped that there. They've told us that photos are available of some of the concerns so that we can view those if needs be. They've given an opinion on the support that they feel has been offered, but they've also noted that parents didn't see that the same way, which again is really useful for us to know. So to know that parents aren't happy with the support that's been offered to date. And there's also a list here of all the other the actions that have been taken. So just go back to the presentation. I'll hand to you, Barbara.
Just before we move on, there will be a chance at the end to ask any questions, but is there any kind of questions around those MARFs? And, you know, is that kind of like the sort of things you're expecting you would put in a MARF? Yeah, okay. And I just want to quickly touch on a point that Baum has made in the chat actually about I think it's at the point a referral we would think is so urgent that we would call the police. So yeah, this is the advice we do give to professionals, that if you think that child is actually at immediate risk and cannot wait, because, you know, as you know, social care are not a blue light service, but the police are. Please contact the police. You know, if that child's going to be in, you know, immediate danger, then contact the police. We do have a system within the MASH called Fast Track, where if your referral hits us quite, you know, soon, you know, within the process, we can have a very quick professional discussion on the floor plate. Usually it is, where we make a decision, right, yeah, we do need to send police and social care out now. So that can happen, and it does happen quite frequently on a Friday afternoon, I might add. But just to let you know, there are processes in place if we are, you know, if a child, the situation is so urgent that, you know, the child needs to be seen very soon. Someone's got their hand up. Claire, did you have a question?
I was actually rather bizarrely late to this meeting because I was on the phone to the MASH. So
oh, great.
Yeah, so it's just one of those situations. I'm a community help officer at East Suffolk Council, and we often don't have huge amounts of information depending on what has come through to us to provide to you. So we would, as I've done today, make those calls to the professionals just to get a little bit of kind of a bit of a sense check, really, if we've got a concern. So I suppose for me, we're giving what we have, but that's sometimes not an awful lot. So today we've got a mum we're a bit worried about, 3 children who we don't know anything about other than their ages, but the tone and language being used in the referrals to us and the lack of engagement thereafter causes a bit of concern. So it's those bits where we can't give you enough, but we have a very, very small amount. You know, we'll send them through to you guys, but it's difficult to give you that information other than what we have. So I'm assuming in those situations, you know, call the professionals line, try and run through what we have got, because if there is that bit of a sense of concern that we have, sense check it with someone. I suppose that's what I'm kind of really trying to say, because I appreciate the more information the better, but we don't always have it, sadly.
I mean, what we're saying, you know, is ideal, that to you know, to provide as much information as you can. Of course, if you can't, we would rather that you referred the child without worrying about getting the information. Because Customer First and ourselves do have access to systems where we can search. So but yeah, I mean, we get anonymous referrals as well, where people give us very little information. You know, it could be somebody, you know, a member of the public walking out on the street and they've heard a household that, you know, where a child is screaming and they haven't really noticed the number of the house and they think the
Yeah.
street is called so and so, you know, and we do get those. But,
Yeah,
you know,
okay.
as I said, we would prefer that you give us what you know rather than not give it to us at all.
Yeah. Okay. So just a thorough kind of, here's all our information. We're a
Yeah.
little bit worried about this family. Okay. That's great. I guess at the minute we don't know if it's mum or the children. We just know it's all of them. So I suppose it's just that, and you'll then work out if it's going to children or adult or a
Yeah.
bit of both, depending on where. Okay, that's fine.
Yeah. Yeah.
Can I
Right,
just
thank you
quickly
very
jump
much.
in there, Barbara, just to say
Yeah.
that if that is all the information you have, just to maybe make that clear on your referral to
just to
stop
say,
customer
yeah.
first coming back to say, have you got anything else?
Yeah.
Yeah.
Okay.
Yeah,
Smashing.
because we do that as well, Laura, don't we? We
Yeah.
just like,
Yeah.
oh, can you ask the referrer if they've got any more information? But yeah, so if you make that very clear when you do, you know, your
Yeah.
MARF, I don't have any other information.
Yeah. Okay.
You know, that would be really helpful and, you know, save us and save time, you know, with responding really.
Yeah. Okay.
Okay,
Thank you.
so before we finish, we're just going to touch on the PCL and web chat. Just to remind people the use of it really, and things like that. I can also let you know some figures around the PCL in September numbers, and we took 369 calls on that PCL. And just to let you know that our PCL line is maintained by our MASH practitioners and our social workers, but that's not their only job, and they have a caseload as well. So while trying to manage a caseload, they're also answering the professional consultation line. We are doing a piece of work around the professional consultation line and the web chat, because we are looking at trying to improve. We're aware that there are some waiting times that we're not we're not happy with, and I'm sure you're not happy with either. So we do need to look into that in more depth. But at the moment, you know, we would encourage you to use it. So I mean, it was designed for professionals only to use. And the majority of the calls we get are from professionals. We do occasionally get a parent, and we're not sure how they get through, but they do. It is for unallocated children and young people, and children that you know to be allocated, you should be contacting their workers. I know sometimes you're not sure, and sometimes, you know, professionals are not informed when cases close, so they're not sure if the case is still open. But I would say contact those teams first. They'll soon tell you that they're no longer allocated. So the purpose of the PCL is to gain advice on whether referral is required. And I think looking at some of our data, we can see that that is what the PCL is mainly used for, which is good, you know, and I think it also helps us to determine and make sure that the right referrals do come through to us. I mean, on both platforms, the professional can have a discussion around the most appropriate and effective way to support the child, which could be through a referral. So again, it's CYPS and adults who have the professional consultation line that you can use, and you get an option when you ring the number. And I think health as well. Our MASH Health have a line as well. So if it's a health related question that you've got, then it will go through to MASH Health. Oh yeah, here we go. So on the next slide. So advice and guidance will be provided by workers within the children's MASH. And then when you call, you're asked to select the correct option. No details feedback can be given regarding specific people or cases, and I know that can sometimes be quite frustrating, but you know, that's not the right place to be asking for that really. And then the web chat facility is there. I think our web chat has previously been more accessible in terms of, like, you might get a quicker response on that than the PCL, but our web chat is getting busier. So yeah, it's, you know, the numbers are increasing on there, but it is something we're looking into. we do want to keep that professional consultation line going. We do want to keep it as accessible to, you know, professionals as possible. Okay, I think that's us.
Okay, thanks, Barbara. There are a few questions in the chat, but we could perhaps come back to those at the end. So it will be Sarah. Sarah, are you able to share your slides?
Yes, I'm just going to make my attempt at sharing my screen. You just let me know when you can see it.
Yeah, we've got them. Yeah.
Lovely. Okay, so yeah, I'm not going to go into all the detail again because Barbara and Millie have kindly covered a lot of the same information in relation to the MASH, who we are and what our role is. But I'm just going to go through the adult process. And yeah, if there's any questions about that, we can cover those at the end. So our let me just make, our MASH structure. So we're a lot smaller in the adult MASH, and the reason for that is because unlike children, we don't have all adults coming through the MASH. We only have the referrals that are submitted for a safeguarding purpose. So Customer First will deal with all of those other issues in relation to needing care and support. So we just have the safeguarding referrals. So we have smaller numbers coming through and we're a smaller team. So our team consists of safeguarding senior social workers. They're pretty much the same as the consultant social work role. We have just over three senior social workers. We have one full-time social worker. We have 4 safeguarding practitioners, which are similar to your community care practitioners, independence and wellbeing practitioners. So they're skilled individuals, but they've not gone through kind of social work training. And we have a small amount of business support as well. We work within the Care Act. So, and it's section 42 of the Care Act that is the legal governance for the work that we do. And to consider whether a section 42 inquiry is required, the individual has to meet what they call 3 statutory criteria. And that's these. They have to have some care and support needs, but that's regardless of whether the local authority is meeting those needs. They're experiencing or at risk of abuse or neglect, and as a result of those care and support needs is unable to protect themselves from either the risk or the experience of abuse and neglect. That seems quite straightforward, but it's not always as straightforward. And the third criteria on there is the kind of real crux for us. As we know, there is various people that may have care and support needs, physical disabilities, things like MS, ME, and they may not need social work intervention in relation to the situation that they're in. So what we're doing is considering their care and support needs, and then considering whether those needs do impact on their ability to protect themselves. Equally, we do have adults coming through the MASH that their care and support needs are really not clear. But what we can see is they're unable to protect themselves. So we are quite flexible with this, and we tend to look at the risk rather than focusing so much on the care and support. Examples of that is people that are experiencing domestic abuse. This may be a period of their life where they are unable to protect themselves because of some coercion and control, or another situation such as mental health. Generally, they could have no care and support needs, but that situation has given them some real support needs and they've been unable to protect themselves because of it. So we are quite flexible with it. And again, we just look at the risk and see whether there is something that we could do to support that individual. We're not always the right service, but we do consider that. So although in the legislation it looks very simple, it's not as kind of clear cut as that. So our MASH journey referral process. So again, all the referrals are made through Customer First. Customer First will identify if it is a safeguarding concern, check that it's been put on the right form, make sure all the relevant information is there for us, and give it a little bit of a kind of a triage themselves. They have some tools to do that, which I'll go into shortly. But it's kind of a light touch triage, because we do have some people that will put things in and they feel it's kind of safeguarding, but actually their needs could be best met through some of our other social work intervention. So our colleagues at Customer First will do that for us. Pretty much the same as children, the referral then arrives into our MASH duty tray. We have our most senior members of staff, so our senior practitioners will manage that incoming tray, and they will be giving a more expert view on the situation and considering whether it is relevant and proportionate to bring that into the MASH. They may at that stage talk to you as referrers. They may also talk to the individual at that point. We're very aware that it's quite intrusive, and when we start sharing some really personal information about a situation that's very personal and quite awful for the individual. So we want to make sure it's proportionate to go through that process first. We don't really work with consent as such. We work again with risk. So the individual may say to us, actually, no, we don't want anything done. And we'll say, yep, that's fine. We won't do anything else with this. But if the risk is quite significant, or there may be risk to others, we'll be telling them that actually, I'm sorry, but we do need to do something with this anyway. So that will be all part of that initial kind of triage by the senior social worker. Once it's decided that it is proportionate to bring that into MASH and do that information sharing, we will send that to our relevant hub. So that's our practitioners that will then speak with the individual again, speak to the referrer. They will then gather all that information from our partners in the MASH, pull all that information together. Sometimes once we've got all that information, it's very clear what we need to do. So we may make a proposal to our partners and say, this is what we think needs to happen. And they will agree, or sometimes they won't agree with us and they feel that something different needs to happen. In those situations, we will go to a threshold discussion. Or if we're not really sure which way it should go, not really sure whether the police would want to be involved, then again, we would have a threshold discussion. We have a number of those throughout the day. We tend to do between 10 and 15 each day, so it's pretty much constant. Again, we try and invite as many people as relevant to that discussion that can bring something to that discussion that will help with that decision. We do need to be aware that that's not a discussion about how any inquiry is going to happen as such. It's more about making that initial decision, and we have to roll them through really quickly. So it's not always possible to give lots of warning about them. And so getting external people into those meetings can be quite tricky. So yeah, we can't always get everyone in there, but we try and get the most relevant people to them. A decision is then made as to whether we are going to apply Section 42 or whether we think that this could be a social care input. Again, going back to the legislation, it's kind of not as clear cut, because someone may actually meet the 3 statutory criteria, and we can apply a Section 42 inquiry, but we may feel that there are other processes that are less restrictive that could support that individual. An example of that can be referrals that we receive that are kind of badged domestic abuse, and they are domestic abuse, but they are as the result of a particular situation such as carer breakdown. So we haven't got a chronic problem around domestic abuse. We have got somebody that's maybe been asking for some support or not really aware of the support that's out there and have got to the point in their caring role where they have snapped. We do really have to consider them alongside the police, because they can be an assault, but we want to make sure the decision we make is going to be one that has the best outcome for the individual and for the carer. So again, although it's very clear about that criteria, we need to think about the best outcome for the person and the most proportionate response for that to happen. In terms of numbers of contacts coming in, again, our numbers are lower because it is just the safeguarding. We used to sit round about kind of 400, but over the last 3 or 4 months, those numbers can go up to near 600. Out of those contacts that we do receive, there's usually only about 50% of those that actually do go through to a Section 42 inquiry. So yeah, there's a good amount of work that MASH will do and move things in a different direction. So just moving on to the tools that you as referrers can use. So we have Safeguarding Adults Framework. There's a link to it on this slide that will take you to the partnership website where it's a live document, so you can get that from there. You can also access through the partnership website the little mini guides. We also have these for children's as well, and there's some fantastic resource on the website, so please do go and use that, and you can order as many as the mini guides as you like. So this is what we use within adults. We put this together a number of years ago now. I think it must be getting on for 5 years ago. It was a multi-agency document. We recognised in Suffolk that our benchmark for abuse for adults was different within different organisations, especially around care quality concerns. The kind of windscreen wiper effect, I call it, of when something tips into abuse and neglect or care quality is quite difficult to navigate and to work out when that tipping point is. So alongside our partners, we sat down for many hours, many days, many weeks, putting together the document so it used the same language. So the hope was that whether you were a health partner, whether you're a police officer, whether you come from education, whether you come from social care, this document would be the same and would give everybody the same kind of benchmark and advice. I'm just going to show one example. So throughout the framework, there's a page for every abuse type within the Care Act. Some have more than one page, and that's particularly around neglects and acts of omission, because there's so many different types around general falls, medication, pressure areas. But there is a page for each one. They're not really scenarios as such, and it should be used as a tool to be able to give you an idea of the type of things that can be dealt with in different ways. So you do have to use it with professional judgment. On each page, you'll see the grey strip through the middle runs through all of it, and that's around what we call making safeguarding personal, which is within the Care Act, and that is that we ensure that the person is central to the process from the point of referral right to the end of it. Again, we can't always do what that individual wants, but they need to be part of that throughout the process. And again, the other grey strip at the bottom will give guidance on other documents that professionals might want to look at to give them some support within that situation. So within the pressure sore ones, there is some additional guidance around that. There's some links and things to things like the Mental Capacity Act. So we kind of look, the red is obviously the reportable concerns. They are the concerns that absolutely we will need referring. The orangey yellow colour are concerns that could be safeguarding but might not, and we need to have a bit more context around them. So they may often be calls that, again, you would phone the professional consultation line to talk about the context around that situation to establish if it is going to fit into a safeguarding arena. The blue and the green are pretty similar, but the blue is more around individuals living in the community and things that might happen to them in the community. And the green is more about individuals living within like a residential establishment, some kind of environment such as that. They are concerns that we would expect to be dealt with through local management. So within a residential setting, we would be looking at a care home manager doing their own incident investigation. Within the blue area and people living in their own home, we may be looking at social workers and other professionals being able to work through that problem with individuals. Within the document, and this is the bit that's kind of more live, which is why it's helpful to go to the website to look at this, is other agencies and other support services, because we also recognise that there are referrers that will have a problem. They'll have a scenario, they're really worried about it, they'll read the framework and they'll see that it's not reportable, but they still don't know what to do with it. They're like, well, I've still got a worry, and I need to put that worry somewhere. So these are a list of different agencies and services that could support the individual, and there's quite a lot of them. And what we do find is that there are new things popping up all the time, and some charitable organisations may shut down. So that's why that bit needs to be kept live. If you know of other agencies out there that are not on the framework list and you think they'd be beneficial, again, do email the website and they can be added. A lot of people find this as a really important and really helpful document in terms of where to go and get other advice. Also, we have a glossary in there. Again, this was because we recognise that terminology can mean, we understand what certain things mean, but they may mean have a totally different meaning to someone within a different organisation, or we might not have a clue what they mean. Cuckooing was one when we first brought the document out. I think everybody knows what it is now, but when it first came out, people were like, what on earth is that? So it just gives an idea of, within this document, what we mean by a clinical specialist, what do we mean by a criminal act? So that can be a helpful guide too. So just moving on now to the referral process. So again, as Millie was saying, it's very similar within an adult world around what things could be done before you actually do make that referral. And one of the most important things for us is to speak to the adult. I've just seen a typo in there. It's not an alt, it's an adult. Speak to the adult and find out what the concerns are. Get some kind of factual information. You're not investigating and you're not going to cause any problems by just getting some facts out of that individual. talk to them about what you're worried about, because what you're worried about might not be what they're worried about, and that might help them give you a bit more information to say, no, that's not what happened. It was this. So have a conversation with them about it. What we do find a lot is that we will receive referrals from people, and the person doesn't even know that referral is being made, and that has the same effect like with children. We're then phoning up that adult and speaking to them about something that could be really personal to them, could be quite distressing for them. Cold call somebody that they don't know. If they know that you're putting that referral in, they will be expecting our call. So it's not going to be a shock to them when we phone them up and say, we've had a safeguarding concern raised for you. Again, we don't need their permission to do that. If they say, I don't want that to happen, and you're still worried and you still think that there's a risk, you can submit that referral. But add all that information into the referral to say, I've spoke to them, they're not wanting this to go any further, but I've still got concerns about ongoing risk. It's also helpful for us to know about the adult's view on the concern and what they would like to happen. Again, we can't always make that happen, but we try and get as close to that as possible. So having an understanding right from the beginning what they want. An example could be a financial concern. We get a lot of concerns around financial exploitation and abuse, and that could be from friends or family. What the adult may want is just for it to stop. They may not want to go down a whole criminal route with the individual being spoken to by the police. And that's fine. If there's not other people at risk, that's their decision. But we'll know from the beginning that we're looking at protecting this person's finances rather than sharing with the police and going down that whole route. Have you looked at the framework? Have you contacted the professional consultation line to see if that can assist you in your decision about whether you need to refer? Also, just considering the adult's mental capacity. We're not asking people to do full mental capacity assessments unless you are that involved with the individual and you're able to do that. But if somebody's telling you they don't want something to happen, and you don't think that they have the capacity to make that particular decision at that time, then that's more of a worry. Again, going back to the financial concerns, if somebody's saying, I don't want the police involved, even though £5,000 gone out of my bank, if they don't have the capacity to make the decision about the risks to them with money going missing, then we may go through a police route for that because they're unable to make that decision. Some top tips. So again, exactly the same as what Millie was saying, include as much information as possible, but if we can keep it as concise as possible and factual, that would be great. Reading through all those referrals, we get some brilliant referrals from people, which gives us a really clear understanding of what needs to happen, what the person wants, what the risks are. But we do also get referrals where there is very little information. You can't make a decision on that with, you need more information. Our colleagues at Customer First can help us make some of those decisions if they've got the information they need to do it. But kind of one or two lines about this person's at risk from Johnny, it's like we don't have the crystal ball, unfortunately. So yeah, factual information. If we can keep it as concise as possible, just because we have so many to read. Has the voice of the adult been included in there? The referral form is set out in a way that kind of points you to all of these questions as well. We absolutely need to know name of the person, their if we can, their date of birth, if not other information that we can identify exactly who that individual is, their address, whatever. And also with the person who's the source of risk, as much information as you can get. Totally appreciate you may not know their date of birth or their address, but especially if we're going to ask for police information, the police need more than a first and a surname for them to be able to do that. Date of birth's great, if not an address, mobile telephone numbers as well. They can sometimes identify the person through that. Also, a best time to contact the adult if you're aware of it. Are they an elderly person and they're very tired in the afternoon, so speak to them in the morning? Or are they somebody that's better off in the afternoon, or don't you know? But if you do know a good time to contact them, that would be great. If there's anything in relation to risk from people in the property, if you could put that on the referral as well, to say if it's say a domestic abuse concern, husband lives there, husband is the source of risk, but we know he goes out every Thursday afternoon. That's great, because we know that good time to speak to the person. And also your contact details, telephone number, email. Email's great because we can get back to you and tell you what the outcome is. Telephone numbers, because of the volume of work, it's difficult to keep phoning people back if they're unable to pick up. And again, a best time to contact you if you're a professional, if you're working in a school or something and you know you're going to be in class, so you can't be contacted before 3 in the afternoon, then just let us know that, and we will do our best to kind of tie that in with the time that we contact you. So some of the possible outcomes that we would have within adults, again, as I said, the decision is always made in the best interest of the adult at risk. Might not be what they want, but it's always done in the best interest of them. We could outcome something as information, guidance and advice. That could be at the contact stage or after the MASH assessment, and that's usually because we've spoken to them, everything's been resolved, we know they're no longer at risk, or yeah, it may have been a misunderstanding, miscommunication. We may redirect to another local authority if the abuse in a different local authority area, then we'll redirect it to them. There are times where we may work with them with another authority in Suffolk because they could live here, but the abuse happened in Norfolk. But we've got the link with them, so we would negotiate that. We may progress to a social care assessment, so a review of their care needs and their care package. We could redirect to another organisation. Again, with our financial concerns, we receive a lot of referrals at the moment about scammers. That seems to be on the increase again. We know that our colleagues in Trading Standards are an excellent service for supporting people through that, and are more specialist than our social work teams in doing that. So we may redirect to them. We may also redirect to the fire service for fire prevention work. The Section 42, it may be a single agency inquiry, or it could be a joint inquiry with the police, or it could also be a joint inquiry with our health colleagues if it's around a health need. The local authority would always hold the Section 42, but we would engage with police, health partners, whoever's relevant, to undertake those inquiries. Our feedback, so feeding back to referrers, I think this is something that comes up time and time again, really, of people wanting feedback and haven't received it. We know we're not as good as we could be. It's something that we're constantly working on and constantly looking at how we can improve, but we do aim to give feedback on all cases where it's appropriate. There are times it's not. The feedback will be directly to the referrer. So we do have situations where we may have got some health information as part of that process, but we haven't necessarily fed back to health because they weren't the referrer. When we need to do that because they need to be part of protection planning, we will do so. We can't always share all the information. It depends on the situation. So we may only be able to share, yes, we've got your referral, we've spoken to the individual and we're taking the appropriate action. Or if you're involved with that individual, it could be more detail. Yes, it's going to be a joint inquiry and this is what's going to happen next. If you haven't received any feedback on a case, if you give us kind of a reasonable amount of time, should be within a week really, then you can contact our ACS MASH duty email. That's the best way to make that inquiry. As Barbara said earlier, the consultation line, we try and keep that free for its purpose. It is answered pretty promptly, so a lot of people do use it when they're frustrated because they can't get the information they need. But if you do need information on a referral or anything else other than what do I need to put this referral in, if you go to that inbox, then it can be looked at through there and we can hopefully get back to you quite promptly. If there's any other information that you have once you've submitted the referral, so you've put your referral in, you've gone back and seen the individual and they've told you something else, then you need to pop that back through customer first and then we can see the appropriate way to add that on. It may be that referral's already ended, so it's not as simple, unfortunately, as just being able to phone up the MASH and say, can I just add this? I think that's the end of my slides. Yep. So I will stop sharing and we can look at any questions. Try and stop sharing. Have I successfully stopped sharing?
Yeah, you have, Sarah. Yeah.
Brilliant.
It's done. It's gone. Yeah. Thank you very much, Sarah. That was really interesting and really useful. Has anybody got any questions or anything they're not clear about or anything else they want to ask? Yeah, I think Mandy.
Hello, thank you, Tracy. Just to Sarah gave an email address there for adults. Is there one for children if we haven't had feedback from a referral we've made, an email address we can contact or phone number to ask about the outcome, please?
Yeah, there is. We'll put it in the chat.
Yeah, great.
That's great. Thank you.
There was a question in the chat which was about when you've got a network of support, if an adult or child is living in a HMO, would you need the names of other residents that they're living with?
So from an adult perspective,
Yeah.
If there's a network of support, again, I would speak to the individual and make sure they're happy for us to contact those people if they are somebody that has capacity to make that decision. Because absolutely, if they've got a good network and there's somebody there that we can speak to that can support them through the process, we would want to do that. I don't know if there's anything from a child's perspective, Barbara or Millie.
Same really. If they're support network, then yes. I mean, I think it's always handy to know that the family are living in an HMO, so that we know there are other people about. And I mean, also if you think that anybody within that household is a risk.
Yeah, Thank you. Yeah, that's what I'd have thought. Yeah, if there were risks to them. Yeah. There was there's another question which is about submitting images. Has the advice changed? As I know early year settings were previously told that they should not be taking photos. What's the advice on the taking images?
I think Millie kind of said if it's appropriate, you know, if it's on a part of the body that is okay to share, those images, you know, especially of injuries, are quite important for us to see, because, you know, our medical professionals in our team can sometimes determine the age or a likely cause by just seeing those images. But of course, you know, we don't want to add distress to a child. We don't want to ask them to be undressed and things like that. But visible injuries, you know, on a face, you know, on an arm or a leg is fine to share. If you suspect they've got other injuries elsewhere, then, you know, that's for us to decide whether we're going to do a paediatric assessment where they can be seen fully. Hope that's all right. Millie, did you want to add anything to that?
Yeah, I was just going to say, in terms of the images, I echo exactly what Barbara's just said as well about it needing to be appropriate images, and only if the child's comfortable with that as well, because that's not fair for us to be putting them through that if that's not something they're happy with. But they're really useful, particularly within our threshold discussions, when we have got the consultant paediatrician with us to consider whether they need to be seeing that child, and it helps them more than us to determine the urgency of how quickly they need to see that child. So if they're appropriate, they always help.
And if I just add with the adults, if the adult has capacity into making the decision about whether you do take a photograph and you send that on to us, you'd need to have that discussion with them, explaining why you're going to do that and explaining where that photograph would go if they lack capacity around that decision, and it's appropriate that photographs taken. It might be around pressure areas or something. Again, if they're distressed by you doing that, don't do it. If they're comfortable with it, then yes, that can also really help us.
Great, thank you. Any other questions? Okay. We will send out the slides. We will send out the slides. I'll get those I've got Sarah's, but I'll get the other 2 sets of slides, and we'll send those out to all of you who attended. And then, if you please forward those on. If you want to forward those on to other colleagues, that's perfectly fine. We have recorded this, so we may need to cut out some of the particularly the bit where it went through the cases, possibly. So we can look at that, how we cut that out. But we thought it was useful to record it, because quite a few people said they wanted to come and then couldn't come. So they would have found it quite useful. So we'll do that as well. But thank you very much. That's been really, really helpful. Okay. Okay. We'll end it. So we'll close there. Thank you.
Thank you.
Thank you.
Thanks.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.